Hello and welcome to this month's European Respiratory Journal podcast. My name's James Chalmers and I'm the chief editor of the European Respiratory Journal, and it's my pleasure to welcome you to this month's topic. And we're going to be talking about a really important clinical problem this month, which is allergic bronchopulmonary aspergillosis. This is something we've not talked about on a podcast before. It's something that many of us see frequently in our clinical practice. It's very difficult to manage. And so we're delighted to have the first author, the lead on a new clinical practice guideline with us to talk about the management of ABPA. And I'll let him introduce himself now.
Thanks, James. It's lovely to be here. I'm Dr. Ritesh Agarwal. I'm a clinical faculty at the Department of Pulmonary Medicine at the Postgraduate Institute of Medical Education and Research, Chandigarh, India. And my research interest is in allergic bronchopulmonary aspergillosis and interventional pulmonology.
Really great to have you with us. So I think what would be great at the beginning is just a kind of overview of what are the main takeaway clinical recommendations for the guideline.
The last ABPA guidelines were published almost a decade ago, and these were from the SHAM working group. So in the last decade, several advancements have taken place in the field of both diagnostics and therapeutics in the domain of ABPA. So these guidelines represent a major advancement and major improvements in the clinical practice. The most important thing, the definition of ABPA has been modified. So initially, ABPA was defined as allergic mycoses against Aspergillus fumigatus. Now the definition has been expanded to include any fungi other than Aspergillus fumigatus. So all the Aspergillus fungi are included in this definition. Hence, the definition of allergic bronchopulmonary mycoses has shrunk. Initially, it was allergic response against fungi other than Aspergillus fumigatus. So now the definition is shrunken to allergic response against fungi other than Aspergillus species. Secondly, ABPA is a common occurrence in many asthmatic patients in several countries. And a misdiagnosis of ABPA is problematic because untreated ABPA can progress to significant bronchiectasis and its antecedent problems. Moreover, the test for screening ABPA is a simple blood test, which is A fumigatus specific IgE. So the new guidelines recommend that all patients of asthma in tertiary care setting should be screened with a Aspergillus fumigatus specific IgE, irrespective of the severity or the level of control, so as not to miss ABPA. The third important change is that we have lowered the IgE cutoff from 1,000 to 500 to get more patients and not to miss anyone. Fourthly, we have changed the clinical classification of ABPA. So we have now devised an objective multidimensional treatment response criteria, which will be of great use in clinical trials. The ambit of the guidelines have also expanded. Now we have a separate criteria for allergic bronchopulmonary aspergillosis and a separate criteria for allergic bronchopulmonary mycosis. Because allergic bronchopulmonary mycosis was a problematic diagnosis. It is uncommon and there's a significant overlap with ABPA. So now we have separate guidelines for ABPA and separate guidelines for ABPM for diagnosing them. This way, the clinician can easily detect these two entities. And finally, the treatment. There's a very important change in the treatment. Now we recommend either prednisolone or itraconazole as first-line therapy. Initially, it was always prednisolone or a combination therapy. So the guidelines categorically says, please don't use combination therapy upfront. Use either prednisolone or itraconazole, not combination therapy, because there's no significant advantage and there's an increased propensity for adverse events. So I think in a nutshell, these are the most important changes that a reader should know in the new guidelines.
That's terrific, Ritesh. One of the big changes then is the change in the criteria. So previously, to have a diagnosis of ABPA, you would need evidence of sensitization to Aspergillus or to another fungus.
Yeah.
And an IgE above 1,000, and that's been lowered down to 500.
Yeah.
So what was the thinking behind that and the evidence behind that?
So two different studies from our group using a statistical model called TAGS, that is test accuracy in the absence of gold standard, we found that the IgE cutoff of 500 offered the same sensitivity as 1,000 and the slightly lower specificity. So you could get more patients without losing the accuracy. So that's why we have reduced, because you can pick up at least 7% more patients if you lower the cutoff, and they are accurate ABPA patients. So they are not noise, they are actually signal there. So they are actually patients of ABPA. So that's why we have lowered the cutoff. Plus, in several geographical locations like Japan and in the UK, the patients of ABPA have a lower IgE. So you will see patients in your practice who have IgE between 400 and 500, but they meet all the other criteria. So recognizing that fact, and because it's a global guideline, so we have decreased the threshold from 1,000 to 500. So this will greatly help in picking up more patients at an early stage so that we can treat them appropriately and prevent the progression of bronchiectasis.
Yeah, so that's really helpful clarification of the clinical criteria. One of the controversies, I guess, now is that for patients with severe asthma who are progressing to the point where they have poorly controlled disease, severe asthma, we're increasingly told not to use oral corticosteroid and to use biologics up front. Certainly in the UK, the practice is moving much more towards using biologics. ABPA is the one subset of severe asthma, or the one driver of severe asthma symptoms, where we're still recommended to use a lot of oral corticosteroid. What did the guidelines say about biologics? And do you think there is a tension here between how we're now managing asthma versus how we're managing ABPA?
ABPA is very unique in that it's a subset of asthma where the organism producing the allergen is actively growing in the airways. So aspergillosis is actively growing in the airways, unlike other allergens, say house dust mite or pollens, etc. So where the patient just gets repeated exposure, here the patient gets a continuous exposure day in, day out. So the allergic response here is profound, much, much more than which you see in severe asthma without ABPA. So if you take a patient of acute ABPA, if you give them biologic, first it would take at least 4 to 8 weeks to bring about its efficacy. Plus, that action will not be sustained. So what is required here is a burst of steroid or itraconazole along with steroids for short course, so that you take care of the profound inflammation and control and bring back the immunological activity to a baseline. Thereafter, it is possible that biologics can play a role in ABPA. However, the evidence currently is not there. So whatever evidence we have is in form of case reports, retrospective analysis of prospective data, and so on and so forth. And in my own experience, I've seen that biologics don't work. So you give them, it works for 4-6 months, and then the patient has a relapse, because here the problem is twofold. One is the asthma is severe, plus if the patient has an exposure to aspergillus, and that's a ubiquitous fungi. So you will get exposure, how much ever you try to prevent that, you will get exposed here or there. So once that fungus grows in your airways, that will incite a profound inflammatory reaction, and biologic, even if it has been working, will fail at that time. So the patient will require a short course of steroid. So I think we'll require more data currently. And in the guidelines also, we have emphasized this point, not to use biologics upfront in acute ABPA. You could use them after controlling the disease in patients who have recurrent exacerbations to prevent the next exacerbation. But an important strategy here is environmental control. So if you say you can take a biologic and you can do whatever you want, that will not be possible. So the patient has to avoid activities that can cause exposure to aspergillus. So there has to be a significant change in the lifestyle of the patient, and that's a problematic thing.
Yeah, that's really clear. And there is a lack of evidence in this area, isn't there? Because there aren't specific trials in ABPA.
Yeah.
One final question. I think we have the perception that ABPA is underdiagnosed, and you mentioned that. I suspect hypersensitivity to the other fungi is even more underdiagnosed because standardized testing against other fungi other than aspergillus is rarely performed. In what clinical context should our listeners be looking for hypersensitivity to fungi other than aspergillus?
In general, ABPM is diagnosed when the patient presents with symptoms and signs of ABPA, say is having hemoptysis, expectoration of mucus plugs, fleeting opacities on the chest radiograph. And you do an aspergillus fumigated specific IgE, and that is negative. So that is one point. Secondly, you do a sputa, and sputa grows an organism, let's say a Phytophilum commune, and it is persistently growing that same organism. So these are the settings where you think that the patient does not have ABPA and possibly has allergic bronchopulmonary mycoses. The only problem here is some patients will have a different colonizing fungi and a different sensitizing fungi. So they'll have Aspergillus fumigatus specific IgE positive, and the cultures would grow Candida or Phytophilum commune. Here, it is important that you do sensitization towards this fungi. So unless and until you document sensitization towards this fungi, you cannot diagnose allergic bronchopulmonary mycoses. And that is why the guidelines categorically state how to diagnose ABPA or ABPA.
That's fantastic. So I think guidelines serve two really important purposes. One is to provide clinicians with up-to-date information about how to investigate and manage a disease, but they can also help to raise awareness of disease. And hopefully the new ISHAM ABPA working group guidelines that have just been published will help to do that and will help our readers to manage what is a really difficult clinical condition. The article is the revised clinical practice guidelines for diagnosing, classifying and treating allergic bronchopulmonary aspergillosis, mycoses, a Delphi statement from the ISHAM ABPA working group, published in this month's ERJ. So please log in and take a look at it and use it to help manage your patients. Ritesh, thanks so much for spending the time with us this month.
Thank you, James. Bye-bye.
We'll be back next month with another topic on the ERJ podcast. Every month we highlight a high-impact article published in the journal with myself and the Deputy Chief Editor, Don Sin, inviting a guest every month to talk about these topics. For this month, many thanks for joining us and goodbye.